Welcome to Ageless and Outrageous. Today we're talking with Dr. Jill Krapf. She's a board-certified OBGYN who specializes in female sexual pain disorders. She is the director for the Center for Vulvovaginal Disorders, Florida, in Tampa, Florida. And she's active in research and has published chapters and peer-reviewed articles on vulvodynia and vulvar lichen sclerosis. She is the associate editor for the medical journal Sexual Medicine, as well as for the textbook, Female Sexual Pain Disorders, 2nd edition. She is a fellow of the International Society for the Study of Vulvovaginal Disease. She's also a fellow and board member of the International Society for the Study of Women's Sexual Health, and she serves on the Education Committee and is chair of the Social Media Committee for ISHWISH. Dr. Krapf also co-authored the trade book, When Sex Hurts, Understanding and Healing Pelvic Pain. She loves to share her educational content on social media at Jill Krapf MD. Listen in as we ask her all things about vulvovaginal disorders. So let's talk a little bit about you as a vulvovaginal specialist. What drew you to that area as a specialty? Because it's not really a separate specialty per se. Tell us about your background and training.
Absolutely. So I trained as a obstetrician gynecologist. I did my training at George Washington University. And then during my final year of residency, I had the exceptional honor of being a chief resident. So I was in charge of all the scheduling, and I was trying to schedule a resident to attend a surgery with a private doc who operated with us now and again. His name is Dr. Andrew Goldstein, and anyone in the sexual health world knows who that is. He's like the grandfather, along with Dr. Irwin Goldstein, of female sexual dysfunction and vestibulodynia, vulvodynia, and so forth. So I was looking for a resident to attend one of his vestibulectomies, and I was short-staffed. So I said, okay, I'll just go. And so I attended, and I soon realized that I had absolutely no experience or training in vulvodynia, in vulvar pain conditions, vulvar skin conditions. So we talked the entire time, and I said, I was about to graduate, and I said, is there any way I can join you in your office? Let me learn more about this. I'm about to be unleashed to the world. Can I learn a little bit about these conditions? Because I have a feeling in practice, I'm going to be seeing these things. And so I did. I joined him. And then that led to, I was doing after graduation, I was doing a medical education fellowship because I thought I wanted to be a dean of a medical school someday. And so I spent as much time as possible with Dr. Andrew Goldstein. I learned how to do vestibulectomies and lysis procedures. I learned all about lichen sclerosis and vulvodynia and all of the things that I take care of now. And then I came down to Tampa, Florida about 18 months ago. Mm-hmm. Started my own practice down here, which is the Center for Vulvovaginal Disorders, Florida. Mm-hmm. And I currently see patients with vulvar pain conditions, vulvodynia, provoked vestibulodynia, lichen sclerosis, lichen planus, all the lichens, mm-hmm. chronic vaginitis that no one can figure out. And I'm also trained in menopause. So I'm a Menopause Society mm-hmm. Certified practitioner as well. So I see a lot of that and sexual health in totality for women.
Right. And it all goes together, certainly. Yes. I mean, it all relates. But I think that story really highlights the point that even in typical OBGYN training, you do not get exposed to these types of conditions. So when a patient goes to her regular OBGYN and says, I have burning, I have itching, I have yeast again, or they think it's yeast again, that their OBGYN doesn't really necessarily have this breadth of training that maybe the patient thinks that she has. Can you address that for us?
Absolutely. I mean, I felt that way when I went through
Mhm.
training. It was a number of years ago at this point, and I do think that things are getting better. There have been a number of my colleagues, and myself included, who are really running a lot of education around female sexual health, female sexual dysfunction. There's societies that are very involved in education now, like the International Society for the Study of Women's Sexual Health, ISWISH, as well as ISSVD, which is the International Society for the Study of Vulvovaginal Diseases. So I think that it's getting out there a little more, but we still have a mountain to climb. Most OBGYNs do not have sufficient training in a lot of these complex pain conditions and complex vaginitis and inflammatory conditions. But it's hard to blame them. As OBGYNs, we are responsible for so much. Your OBGYN is delivering babies, all the obstetrics. Depending on where you're located in the country, you may be doing high risk obstetrics, right? As well as hysterectomies and workup of abnormal uterine bleeding. And it's just so vast. So it's impossible to be good at everything. And that's one of the reasons I wanted to specialize. And I believe in the future, I think that vulvar pain conditions, vulvar skin conditions, this vulvar specialist role may end up being super specialized, possibly a fellowship.
Right. And I think that story almost parallels the story of urogynecology in our field because many physicians, myself included, were practicing urogynecology for many, many years. But when I graduated my residency, it was the exact same. There were 3 Urogyn fellowships in the country, none were accredited. And believe it or not, my residency director actually discouraged me from entering them. I went to my residency director and said, I don't know much about the pelvic floor and female incontinence and prolapse. I mean, I've seen a little, but I'm just like you did. I was like, I'm about to see these patients 24/7. And he told me, no, don't waste your time, stick with general OBGYN. And then over time, I just realized I had to do it myself because my patients needed it and I didn't have the knowledge to treat them. And then eventually it became a board certified subspecialty. So it would be great to see that happening for vulvar pain conditions, where we can move along and then patients can really know that the provider they see has the knowledge and experience that they're looking for.
Oh, absolutely. And the fun thing about sexual medicine is it is a team sport, is what we say. So really, to be in sexual medicine, you can be a primary care doctor, you can be a urologist, you can be a urogynecologist, gynecologist, and so we really all work together, and especially with our psychologists, psychiatrists, colleagues as well, our pelvic floor physiotherapists. So I love how collaborative this area of medicine is. But I do think that as the research develops, as the education and acceptability develop, we are going to see more and more vulvar specialists.
Mhm.
And then eventually, just like with urogynecology, I think we're going to see that, more acceptance
Mhm.
of a specialist in that realm.
Exactly. So let's talk about some of these conditions that you see and that a lot of people see every day. So the first one is now called GSM or genitourinary syndrome of menopause. And obviously, anyone who does menopause medicine is going to see a lot of this. But I still think probably a lot of patients are unaware of just all the breadth of symptoms that GSM can cause them if it is untreated.
I absolutely agree. I mean, the terminology GSM is not new. I mean, it's almost a decade old at this point, yet our patients don't really know what GSM is. I think it's kind of coming around with our colleagues, but there's probably colleagues that still refer to these things as atrophy, right? Which they are. That's the medical terminology for it. And unfortunately, our billing codes have not caught up with any of this, which is a
Right.
whole other discussion. But yes, GSM really encompasses all of those hormonal sequelae of vaginal symptoms, vestibular symptoms leading to dryness, discomfort, pain with intercourse, pain with insertion of any type. And so that is a lot of what I see, and it overlaps with a lot of other potential pain conditions as well, such as vulvar dermatoses like lichen sclerosis. So learning about GSM, learning to address it is really, really vital. I think that one of the benefits I've seen from actually social media has been awareness of GSM among patient populations. But it does still surprise me how people do not know that terminology. I had a post recently, I believe it was last week or the week before, where I was discussing the overlap of lichen sclerosis and GSM. And I was in a rush. I inadvertently forgot to explain what GSM, the
Oh,
acronym, was.
right.
And I couldn't believe how many people messaged me or put out in their comments, like, what does this mean?
Yeah.
What does this mean? But it was a great discussion point to launch off of, because just by asking that question, it brings attention to it. And I think words are really important. We need a way to describe what is going on with us, right? That allows us to communicate with our doctors. So I think that it's going to become more well accepted, obviously, among patients, and we have a variety of treatment options for GSM at this point.
Absolutely. And I teach my patients and students and everyone that same thing. Atrophy is one part under the big umbrella of GSM. And you mentioned all of those vulvar and vaginal symptoms, but bladder symptoms as well are all in there. Irritability, frequency, urgency, feeling like you have a UTI, even though it may not be supported on testing, but really feeling those burning sensation. All of that is part of GSM. So when you really start to list out all of the potential symptoms, it's really huge, but that also means that treatment of GSM is big bang for your buck because you treat so many of those symptoms, or at least begin the treatment. It may not be the end all treatment, but it is certainly an important place to start.
Absolutely. And I think one of the wonderful things about the terminology is it did highlight that urologic component that is so vital in GSM. The bladder, the tissue of the bladder, the urethra is very similar to what we see at obviously the vestibule, because the urethral meatus is at the vestibule. There's studies that show that the vaginal microbiome does play a role in what's going on in the bladder with recurrent UTI and so forth. Over my career, and I'm sure over your career, we've seen the changes as far as fear surrounding these medications, such as even vaginal estrogen. And it's funny because the studies on this, looking at systemic absorption, are actually quite old. It really took a while to catch up and really dispel those myths and the fear surrounding this. And then the next thing that we both saw in our career was the concern with breast cancer,
Yes.
right? And estrogens. And there was the question, I remember, maybe it was 5 years ago, being at a conference, and in the hallway where all the
Mhm.
action happens, we're talking about, what, do you feel comfortable prescribing vaginal estrogen for women who have had breast cancer, right? And what do you use? And how do you discuss with their oncologist and so forth? And now we know that it is absolutely safe to use low dose vaginal estrogen for women who have had breast cancer. And so I think that, it's interesting seeing pendulums swing and the tides turning with these treatments, but it's really important to differentiate low dose vaginal estrogen from systemic or whole body estrogen that's used for whole body menopausal symptoms.
Absolutely. I have that safety discussion about local vaginal estrogen multiple times a day when I'm seeing my patients in clinic. When the patients read the insert that comes with their vaginal estrogen product, it reads exactly the same as that systemic whole body estrogen insert. And it mentions stroke and cancer and blood clot risk. And all of those things have never been shown with local vaginal estrogen. And it takes a little bit of time to really get the patient to a place of understanding where I can say the route of this drug is critical to understand. And you using it vaginally, it will stay local to the vagina and bladder, fill up all those receptors there, make a huge difference for you without giving you a systemic level.
Absolutely. And it is really undermining, to provide all that education and then to have a package insert that is supposed to be trusted with such misinformation about a specific product, because we're really doing women a disservice by propagating fear or misinformation around a medication that has a completely different safety profile than what's demonstrated in the package insert that actually pertains to other medications and is definitely out of date.
Because it's just so important that we give our patients fair and balanced information and not inappropriately fearful information. But in addition to GSM, probably something you see tons of is something called lichen sclerosis. And there's another condition also called lichen planus, all these vulvar dermatoses that can happen. Sometimes patients are completely unaware of these conditions. They're not talked about in the general population. And while their GYN may know something about it, they may not know everything to really look for lichen on exam and then give them the proper treatment.
Absolutely. Lichen sclerosis is a condition that is near and dear to my heart. I've dedicated my career, my research to lichen sclerosis in part. And that's because it's a condition that is associated, it has at least a 5-year delay in diagnosis. It's anywhere between around 3 to 20 years as far as delay in diagnosis. So, I think we're getting better with awareness. We used to believe it was a rare condition, but I don't believe it is a rare condition. I think that we're just not seeing it. We're not picking it up. We also used to believe that this was a condition that only occurred in two subsets of our lifespan. We knew that it occurred in the pediatric population, but then the thinking was that it went away in puberty, and then we knew that it occurred in postmenopausal women or women after menopause. But we now know that actually anybody of any age can have lichen sclerosis. It's more likely in women. Lichen sclerosis does occur in men as well. It's most likely in the genital area, including the vulva, as well as the perianal area. However, it can also occur in other parts of the body as well. And so there's just a lot of misinformation about this condition. And the other thing that was very murky for a long time, but we're finally getting a handle on, is the cause. So lichen sclerosis, we now know, is an autoimmune condition. It's an autoimmune inflammatory skin condition. And I'm actually very proud to be a part of the study group that was involved in collecting the biopsies to help determine the genes that are upregulated and downregulated in this condition.
That's so exciting to hear. I mean, just being able to tell patients why it happens, because I remember when I started my career, I would talk to them about lichen and say, well, we think it could be autoimmune, but we're not sure. It could have some other sources. So being able to give them an answer is really validating for that patient. But now being able to validate their symptoms, biopsy if necessary, know the cause of the disease.
Exactly. And I think that we need to weigh everything out when we're talking about a treatment plan. What I see in many cases is if we do identify lichen sclerosis, we're often missing treatment of other conditions that are present as well. So patients will come in with lichen sclerosis and perhaps they're using a topical steroid, but they were never given instructions on how to use the topical steroid. And so there
Or
is
how long to use it.
exactly how long, how frequent, to rub it in, whether you use a cream or an ointment, what the idea behind that is. And so we see a lot of conditions that are related or side effects, like overgrowth of yeast on the outside, on the vulva or perianal area, due to overuse of a topical steroid or applying it like a thin layer, like icing on a cake, when it really needs to be rubbed in. We know that inflammation in lichen sclerosis is in the bottom layer of the skin. When we do a biopsy and we look, the pathologist looks at the biopsy specimen, that inflammation, those white blood cells are all in the bottom layer. And so The other thing that we may miss is GSM, right? And so if we are just applying a topical steroid but not addressing GSM, especially when it comes to the vestibule, the vulvar vestibule, then we're missing a big piece of the puzzle. And because topical steroids have the potential, if they're not used correctly, to cause atrophy of the tissue, we either need to counteract that in a certain way or make sure we're using the tool in the correct way to limit side effects and to enhance the positive parts of whatever medication we're using.
That's so important. I have so many people who tell me they were given a topical steroid and their provider told them apply a thin layer.
Mhm.
And to a patient, that sounds like ice a cake, just put a thin layer and let it sit versus trying to actually get the product to where you need to treat it. And whether their provider didn't know to educate them or, the patient didn't understand, it's not happening. So then the bottom line is they're not getting all of what they need.
Absolutely. I think a lot of the situations where people feel that the steroid didn't work for them or they're not amenable to treatment, like it's not working, is because they're not applying the steroid correctly,
Mhm.
in my opinion, or their GSM is not appropriately treated in conjunction, or there is something else also going on, whether that be hypertonic pelvic floor muscle dysfunction, which is limiting blood flow and increasing fragility of the tissue, on top of lichen sclerosis skin. So there's usually other pieces of the puzzle that we have to identify. But the idea with lichen sclerosis is that, like we said, the inflammation's on the bottom, and inflammation, which is an autoimmune process. So for simplicity's sake, there's a protein in the basement membrane or the very bottom of the tissue that the body identifies as not self, right? That's what makes it autoimmune. And then the body, the local immune system within the skin, brings in inflammatory factors to fight that protein. And then the inflammation changes the way that our skin cells regenerate in the layers above. And so in the middle layer of skin, we see collagen deposition in a haphazard fashion, and that creates a lichenification or a thickened middle layer of the skin. Thick skin is itchy. That is what causes the itch associated with lichen sclerosis. And then between the top and the middle layers, we have a zipper-like quality called reedy ridges, almost like the top of a castle, right? And it hooks the top layer of skin onto the middle layer of the skin. We see blunting of that zipper-like quality, which leads to shearing, and blood vessels can be disrupted. You can have bruising. It explains some of the signs and symptoms that we see with this condition. And then the very top layer of skin actually becomes atrophied or thinned out. And then we have keratinization of the very, very top layer. And that's what we see when we do a biopsy. So what I recommend to patients as far as treatment, if we were just to put a thin layer or icing on the cake, a topical steroid, all it does is decrease inflammation, right? That's number one.
That's
So
it.
we have to know what we're dealing with. A steroid, whether you inhale it, for asthma, or whether you take an oral one, or whatever you do, it only decreases inflammation. It's not going to bring the hormones back. It's not going to release your pelvic floor and restore blood flow. Like, it's not this magic thing. It only decreases inflammation. But in order to do that, it needs to get to where the inflammation is. So when we put a thin layer on the top, like icing on a cake, it actually thins out the already thinned out layer. And then if there's any propensity for yeast or exposure to bacteria, that can settle in and we can have a superimposed yeast infection, not the kind you pick up with a vaginal swab, right?
Right. In
But
the
more like, yeah, more like that baby diaper rash. So
Mhm.
that redness, that peeling, flaking of the skin, satellite lesions, right? All of that, which we commonly miss actually. Or if there's a bacterial superinfection, it increases the risk of all of those things. The problem is that all of those things feel like itching, burning, rawness, discomfort. And so then we think, right, as a patient, well, my lichen sclerosis is worse. I need to put on more steroid. And you're not putting it on in the right way. So it's making that worse and worse and worse.
Right.
So the way that I advise patients, in addition to obviously identifying any of those factors, is to soak prior to application of steroid if they are active, meaning if the tissue is thickened, right? And we can tell that as doctors by looking at the quality of the tissue, the texture of the tissue, for that crinkled wax paper consistency. We used to say cigarette paper, but no one
Yeah,
knows what that looks
that's not
like.
PC anymore to call
Yeah,
it
no,
cigarette paper.
I know. So we're looking for actually the thickening of the skin. And the way that I explain it to patients is I wish I had X-ray eyes. I wish I could see the inflammation in the bottom layer of the skin. I can't. But it's like taking a bucket of muddy river water. If I took a bucket of muddy river water and I swirled my hand underneath, that's the inflammation. You wouldn't see my hand, but you would see the ripples on the surface. So the skin texture is how we as specialists can tell if lichen sclerosis is active, meaning there's high levels of inflammation, which thereby increases our vulvar cancer risk, right? Or whether it's in remission, meaning the skin texture is normalized. Now, if someone's in remission, they have lower levels of inflammation, right? So they're usually not going to have the itch symptoms, but it does not mean that they're asymptomatic always, because they still, remember, steroids do not reverse scarring.
Mhm.
They do not bring back hormones. They're not going to treat GSM. And so there can be other symptoms like from scarring, including dyspareunia, pain with intercourse, tearing, and so forth, that we can see even if somebody is in remission.
So
But
when
when
your patients go into remission, how do you counsel them to continue to manage their condition? Because a lot of them will feel better and therefore think, well, I don't need my treatment anymore, or the condition is gone. Is that correct?
Yeah, so no, yes and no. So basically, so when someone is active, I do have them soak and then I apply a topical steroid. I have them rub that in sufficiently. It has to be well absorbed. Now, you can imagine if they're active and that layer is thick, even if they're doing everything in the appropriate way, there's only a certain percentage that gets down to the basement or down to that area where that inflammation is. It also takes a while for skin to regenerate. Like, we're not talking days, we're talking weeks to months, right? It can take up to 6 months for severe active lichen sclerosis to become in remission. And so I usually start with a once a day regimen if they're active. I will not do that for someone that's not as active,
Right.
every other day or 2 to 3 times a week, depending on what they need. But if they are active, I do have them soak. Now, once they become in remission, they do not necessarily have to soak because they don't have the thickened layer in the middle, right? They can
Right.
do a warm shower, and then they can apply, but they do still need to rub in the medication. The interesting thing, I prefer ointment instead of cream. The reason is because ointments are lipophilic, meaning lipo is fat, philic is love, fat loving. And remember, that basement membrane, that bottom layer of skin, is attached to the fat layer, right? That's what attaches the skin to our body. And so when we apply an ointment appropriately and it stays in that layer right above the fat layer, it stays there for about 3 to 4 days. 3 to 4 days, 3 to 4 days. That's twice a week.
Right.
That's how we got a twice a week maintenance regimen. So to answer your question, when someone's in remission, they don't necessarily have to soak. If they like to do that, that's fine. If they don't and they're busy, that's fine as well. I have them apply a pea-sized amount of a topical steroid. A little bit goes a long
Mhm.
way. It's very common to apply too much. You really only need a small amount. And I have them apply that generally twice a week when they're in remission. There's two schools of thought once you're in remission, and this is supported by the major European guidelines. So one school of thought is that once you're in remission and asymptomatic, then you can stop, right? And you just monitor and you wait, and then symptoms either come back or they don't. We
Mhm.
have to remember there's a lot of things that affect how our local immune system as well as whole body immune system works, right? There's diet, there's exposure, there's stress, there's hormones, right?
Mhm.
So a lot of things affect basically our immune response. It's just the topical steroid gives us that insurance policy to keep things suppressed or quelled. And it's the only it's the only treatment that has been shown in studies and meta-analysis, so collection of all the data, to actually decrease vulvar cancer risk, right? That we've had so far. So one school of thought is to treat until you're in remission and then stop. I do not subscribe to that. I personally recommend a maintenance treatment. So typically twice a week. Sometimes I'll do once a week. Sometimes I'll do 3 times a week. It really depends on someone's
Mhm.
clinical picture.
Right.
But generally a maintenance treatment, and that is lifelong
Mhm.
because lichen sclerosis cannot be cured.
Mhm.
It is manageable, but it's not cured. Just like thyroid conditions, just like any of these other autoimmune conditions. And so that is what I typically recommend for my patients is a maintenance regimen, typically twice a week for long term.
Right. And, it's to that point that a lichen cannot be cured. As we get better treatment, if we could target the source of the problem, the autoimmune, the body attacking its own proteins and cells, that might actually at one day be a cure for lichen. So if we can stop the damage from happening, but of course, right now we don't have that unless you're aware of any treatment or research being done in that area.
Yeah, we're getting better. So, even if we could figure out what sparked it in the first
Mhm.
place, then I think we would have a chance at a cure. I don't think we're anywhere close to that, unfortunately. However, if we could just target that process a little earlier and then have a more targeted treatment instead of a more blanketed treatment, I think that we could have a topical that would have less potential side effects. And we are getting closer with that. So one of the things that came out of the research on the inflammation process in this condition based on the biopsies is targeted JAKs inhibitors.
Mhm.
So, Janase kinase inhibitors that are targeting a very early piece of the inflammatory pathway. And so they're currently FDA approved for vitiligo as well as atopic dermatitis, so eczema, right? And these things are in, similar families because with lichen sclerosis, we have the inflammation attacks the melanocytes or the
Mhm.
pigment in the skin, and that's what results in that hypopigmentation or the whitening of the skin. So we have that element that's similar to vitiligo. The difference is with vitiligo, and they're both autoimmune conditions. The difference is with vitiligo, there's not an inflammatory component, and there's not a scarring component.
Mhm.
So there's not an itch or scarring component, but there is a hypopigmentation component. And then with eczema, right, that is thickening of the skin to a much lower level. In eczema, the inflammation level is much lower than lichen sclerosis. Lichen sclerosis actually has the highest level of inflammation out of all of the dermatoses, even more so than psoriasis, which may be
Wow.
surprising.
Yeah.
But it produces a huge amount of inflammation. But there's clinical trials that have been done in the setting of lichen planus as well as lichen sclerosis involving JAKs inhibitors. It's just a matter at this point of funding,
Mhm.
research funding. But I do think that there's promise, and I'm hopeful for the future when it comes to these very targeted therapies.
That's so great. And you mentioned the scarring. So we know that lichen sclerosis is unfortunately a scarring condition. So even if the condition itself is calmed down, like you said, their symptoms are improved and their inflammation is held at bay, if scarring has already occurred, that has not gone away. That's still present, even though they may not have itching, burning, active lesions. How do patients deal with that?
Yes, and this is such an important part, right? To know that the treatment with topical clobetasol is in a vast majority of cases not going to reverse scarring. Right.
Right.
I never tell patients to expect that. And in practice, I've only seen it a handful of times. And who knows if it was due to other factors. Right. But the scarring and lichen sclerosis, unfortunately, we don't have a great solution for that. So generally, I counsel patients. And the other thing too, before I go into that, so scarring involves clitoral phimosis, which means coverage of the clitoris, and that can be varying degrees, anywhere anywhere from mild, moderate, severe, meaning completely covered, where we do not see the glans clitoris at all. And then when it comes to symptoms related to that, we don't have a ton of research, but clinically, I can tell you that and I'm curious to hear your thoughts as well. A majority of patients with clitoral phimosis actually do not have clitoral pain or decreased sexual function as far as clitoral function goes. So a majority of patients are able to orgasm. They don't have clitoral pain. Now, there is a subset of patients, and we honestly don't know what percentage that is. It's just the research just hasn't been done on it, that do have clitoral pain and do have decreased sexual function, meaning it's harder to orgasm. They lost their ability to orgasm. They can't orgasm at all, or it's hypersensitive, right? To stimulate. And so for those patients, our options basically include scar tissue release. So working either on their own or with a pelvic floor physiotherapist for release of that tissue. Usually, obviously getting the LS in remission is the first step. But we can do some release with the addition of a topical hormone. And we're looking at, obviously we have estrogen, but one thing that I think we're going to see more and more of in the future, and we're already seeing the studies being done now, is androgens, which mean testosterone, right? Testosterone is extraordinarily important. We as women have testosterone, right? It's not that men just have testosterone and women just have estrogen, right? Men have estrogen as well. And so what we're finding is that testosterone and androgens, which testosterone is an example of, they play a very big role in the vulva and likely in the urethra, and the bladder and the vagina as well. It all comes down to receptors, right? So a hormone, right? If we go down to our basics, a hormone is something that's produced in one place and acts in another. And I tell my patients it's like the postal service, right? If you have a mailbox, then you can get a letter. So you have to have a receptor in tissues for the hormone to bind to it, for the hormone to have effects in that area. And so what we're finding is the vulvar vestibule, which is that opening of the vagina, it has a lot of testosterone receptors. Okay. It has some estrogen receptors too, but it seems to have a lot of testosterone receptors, and especially the glands that produce our natural lubrication, those lesser and greater vestibular glands. We used to call them the Skeens and the Bartholin's glands. We still do.
So we're getting away from everybody's name.
We're trying to get away from
in
naming
medicine. Nothing's right.
women's
Not
anatomy
doing this
after old
anymore.
men. Yeah.
Exactly.
But anyway, so these seem to be very controlled by testosterone, and that's why some of the newer therapies, such as vaginal DHEA, which is a precursor of estrogen and testosterone, seems to have such utility and has been FDA approved for superficial dyspareunia or pain at the vaginal opening, because it hits those glands at the vestibule, which makes a bigger difference than estrogen alone, most likely. And these studies will come out, and we're going to see more and more of this.
Absolutely. And patients, I know a lot of providers will compound testosterone cream for use in the vestibule or the vagina. And it was even a treatment for lichen sclerosis years ago. It was the kind of go-to treatment. I remember when it was still called cigarette paper look, you would treat that with testosterone cream.
I'm so glad you brought that up, because I find this so interesting. I love the history of medicine, and
Yeah,
I'm
me too.
also a big geek with like Latin terminology and where words come from. But what's really interesting with the history of lichen sclerosis is, yes, testosterone was a very early therapy, and it did seem to help. And then it was completely debunked, I think, when we started to learn more about the inflammatory process. But like everything else in medicine, a lot of these things come full circle. So my belief with this is that we need testosterone for the vulva, which is what is affected by lichen sclerosis. And that taps into that GSM component that we often see an overlap with the GSM and the lichen sclerosis, because the majority of lichen sclerosis still does occur in postmenopausal or perimenopausal women, even though it can occur in other time periods as well. I want to enforce that. But I think that is why those really early studies did show utility with testosterone. And then we came away from it for so long. And now I think we're going to come back to it, knowing now that testosterone plays a role in that GSM component, which helps with tissue regeneration and the tissue quality that we need to optimize, in addition to obviously decreasing inflammation of the condition.
Right. And testosterone is such an anti-inflammatory hormone all over the body. So it makes perfect sense that when you apply it to receptors in the bladder and urethra and vulva, it's going to be anti-inflammatory there. And maybe we should be looking at treating GSM not with estrogen alone, which we know is powerful and successful, but estrogen plus testosterone, because women experiencing GSM are losing all of their hormones, estrogen, progesterone, testosterone, not just estrogen in isolation. So I think looking at how these hormones work in concert with each other, not each one in its own little column, because the receptors, as you said, for those hormones are all over there. So of course there's going to be effect at the lower genital structures.
Yes, I am in 100% agreement with you. In fact, this is how I have been practicing for 15 years. So I compound estradiol, the same percentage as what you would get in the prescription medication, like your estrace, right? Or your estradiol, which is generic, with testosterone. And I have patients apply that to the vestibule, which helps with the urethra. It helps with your greater and lesser vestibular glands. It helps with the tissue of the vestibule. And I do this for GSM as well as hormonally associated vestibulodynia, which we can kind of think as like a physiologic subset of GSM.
Right.
It's just not in menopause,
Right.
right?
Mm-hmm.
We want to, one of the downsides of the terminology GSM, even though it's done a lot of good, one of the downsides is it really kind of pigeonholed us in menopause, but we now know that the same processes with a hormone response happen in perimenopause, or it starts to happen at that point. We see this in postpartum and lactation, right?
Mm-hmm.
Breastfeeding. In fact, we recently, Rachel Rubin and I recently published a paper coining the term GSL, which
Mm-hmm.
stands for genitourinary syndrome of lactation. It's the same exact process related to decreased
Right.
estrogens and androgens in these tissues.
Because
And then
the hormone balance is similar in that lactating woman as it is in a menopausal woman.
absolutely. And then we see this in response to different medications, which is a little more controversial, but it makes sense, right? And we think that, and those types of medications are medications that are going to decrease our available testosterone or our calculated free testosterone. And those medications have the potential to be, right? Combined oral contraceptive pills in some people, not in everyone, as well as certain medications that we use for acne, like spironolactone, right, which is an anti-androgen. So it makes sense that that this physiologic process can happen due to different causes. What it would be really interesting, I would love to do this study, but we don't, there's just no way we could do this study, like from a funding and a longevity standpoint. I would love to follow a patient throughout their lifespan, because it would make sense that somebody who had these sort of symptoms on a birth control pill, because perhaps they have weak testosterone receptors
Mm-hmm.
at the vestibule, right? They were born with that. It's
Mm-hmm.
like a genetic predisposition.
Right.
They would likely, if they develop that with birth control pills or spironolactone, they may develop that in the postpartum period.
Right.
They may develop that in perimenopause and menopause, right? Like that would
Right.
make sense.
Because
Now,
their receptors are genetically determined to kind of lean that direction.
exactly. And we do have a study that was actually done by Andrew Goldstein that showed that. So actually, I was on the study as well. So we looked at basically women who were on birth control pills specific, actually fourth generation. So our
Mhm.
Yasmin, Yaz, the drospirenone birth
Right.
control pills, which are especially anti-androgenic.
Mhm.
We looked at women that were on that, and we took a subset of women that had vulvodynia, vestibulodynia, and then a subset that had no issue at all. And we collected blood samples and we sent it to a special lab in Israel, and we looked at the testosterone receptor. We looked at CAG repeats in their testosterone receptor gene. And what we found is that the women who developed sexual pain on the medication had more CAG repeats, meaning they had more convoluted gene expression, meaning weaker testosterone receptors.
Mhm.
And so that makes sense, right? If you have a weaker testosterone receptor, it doesn't bind testosterone as well. When you decrease it down to critical levels, the person with strong receptors is going to get by, whereas the person with weak receptors is going to have pain symptoms. And so that's our theory. It obviously needs to be replicated in larger studies, but there's just no funding for
Right.
anything like that. But it makes sense why some people develop vestibulodynia with these certain triggers, or why some people are worse with menopause,
Mhm.
whereas others are not.
Exactly. I think that that holds true for hormone treatment all over the body, because just like you used your analogy of if you send a letter, you can get it if you have a mailbox. I tell my patients lock and key, right? You have all these little keys floating throughout your body, and they have to find the lock that they fit into, the lock being the receptor and the key being your hormone. So if the lock is broken or a little bit mangled, the key goes in, but not perfectly. And therefore, the hormone may not have any or all of the effect that we want it to have. And I think that's so great to hear that research, because I always tell my patients the missing piece of information when I give you hormone therapy is I can follow it in your bloodstream, but that's just the keys floating around in your bloodstream. I don't know how those keys are doing, opening the locks or getting into your cells and actually giving the outcome that we want. And that's exactly what you're proving at the level of the vulva.
Absolutely. And I remember when this study came out, there was a lot of question like, well, why don't we test for this, right? Like, why don't we screen to see who we would put on birth control pills or not? But from a cost standpoint, number one, we don't have the widespread utility to do that. It was a specialized lab and the cost is too high. So it just doesn't make sense. And a vast majority of people who take birth control pills actually don't have these pain symptoms. So I think the most important thing to take away from it is that it exists,
Mhm.
right? So when somebody comes to you and they say, I have pain, we have to think about that as a potential risk factor along with the other risk factors that are more well established.
Exactly. I think that's so helpful. And going back a little bit to the scarring we were talking about. So we talked about that we might heal the lichen or improve the symptoms, but if scarring is present, it's likely going to persist. I see this all the time in my sexual health patients because, like you mentioned, doing a good exam starting at the clitoris and looking all around is not always done when women go in for a routine GYN exam, but actually pushing back on that clitoral hood and seeing, can you visualize the clitoral bulb? How far is it exposed? And as you mentioned, even if it's not exposed, not all women suffer a symptom due to that. But I found that pain is not too often, unless when I open up that hood, they have a little bit of almost like an ingrown hair or something kind of caught between the hood and the bulb itself. What are you seeing those types of conditions with pain?
Absolutely. So in my experience, the people that have clitoral pain with clitoral phimosis usually have moderate to mild clitoral
Mhm.
phimosis. And so what we see, and I published on this as well as Dr. Rachel Rubin, who's one of my colleagues. We were looking at something called keratin pearls.
Mhm.
So keratin pearls, basically we have dead skin cells that slough off naturally all the time. But in that area where there is moisture, there can be almost like a balling up of these dead skin cells. And when they get trapped in the adhesion or the stickiness of the clitoral hood and the clitoris in the setting of clitoral phimosis, they can ball up under that area or get adhesions can develop over that area. And they form these concentric circles of keratin that actually look like a little pearl. And it's like having a grain of sand in your eyeball. The clitoris, we now know, has over 10,000 nerve endings. That came out a few years ago, that study. And so you can imagine that having a nodule or a foreign body next to the clitoris can be quite irritating, quite painful. In addition, we can find debris, we can find cut pieces of hair. We can find smegma, which basically just describes that white, skin kind of sloughing that we see. And as women and girls, we are not taught how to clean the clitoris. Usually, young boys, especially who are uncircumcised,
Right.
they're taught how to pull back the foreskin, how to clean smegma from around that area. But as girls and women, we are not taught about that. And people can be different levels of smegma producers, right?
Right.
And it's probably related to hormones. I mean, this is a whole area of research there. But some people produce more smegma than others. But what I find is the people with clitoral pain tend to not be completely phimosed. That's not always the case, but I typically see that. And that brings me to kind of the second level of treatment for this. So what I do for my patients, with obviously consent and full discussion, is I offer them lysis procedure. So there's two ways to do that. If you have moderate to mild clitoral adhesions, you could do what's called a in-office lysis of clitoral adhesions, which is basically taking a blunt probe, or my urology colleague Rachel, she uses forceps or a clamp.
Little
And
hemostat or something. Yeah.
yeah, as gynecologists, we were, I don't know if not everyone was trained in circumcision, but some of us
True.
were. And
Yes.
so we tend to use the skill set that we were taught or we were trained with. So I use a lacrimal duct probe,
Mhm.
and then you basically separate the glands from the clitoral hood very gently, and resolve the clitoral phimosis that way, clear out any debris, keratin pearl, smegma, and so forth. So that's one way. If there is moderate to severe clitoral phimosis, then we do what's called a dorsal clitoral slit procedure, right? Which involves just a little bit more technique with uncovering the clitoris. So those are the two available therapies that we have. Now, there's also some energy-based treatments that are out there. However, we don't have good studies on if they are able to reverse fusion, if they're able to resolve clitoral phimosis or clitoral adhesions. We just don't have that evidence widely available or published yet. And I personally, I don't know about you, I actually don't do fractionized CO2 laser.
Mhm. Yeah, and I agree. I think there's data coming for that. Just like anything new and novel in medicine, it starts off where we say we don't know the benefit and or the risk, and we need to continue to gain data on it and know what it does in these populations. But I think even just examining the clitoris and teaching patients how to look at their clitoris. I have the mirror out constantly in my exam room and my little Q-tip as a pointer, and I'm kind of teaching patients the anatomy and what is normal and what is their personal anatomy. And you probably do the same. I have women in their 50s and 60s who say, I never had any idea that this is what it looked like, or that's what it was called, or no one's ever taken me through that type of education.
Absolutely. So in my office, because this is all I see, I
Mhm.
actually have a camera that connects to a TV screen,
Right.
and it's under magnification. I use a vulvoscope, which is essentially a
Mhm.
colposcope, and we look with light and magnification and trained eye, and I go through for all my patients with vulvar pain conditions and vulvar dermatoses, like in sclerosis. I go top to bottom, outside to in. We identify any changes that are related to not only that condition, but also hormonal conditions, including GSM or anything else that may be present. And we really go over everything. And then I obviously have a mirror as well, which I utilize all of the time. And it's really interesting about anatomy because I've definitely had a majority of patients, number one, have said, well, I don't believe my gynecologist looks at my clitoris, right?
Right.
And which I think hopefully the education is getting out there. If I could change two things for the general gynecologist or give two recommendations as a vulvar specialist, I would say number one, examine the clitoris.
Right.
Examine the clitoris. If someone has 70% to complete phimosis, or even 50% to complete phimosis, they most likely have an inflammatory skin condition, right? There's very few things that can produce complete coverage of the clitoris,
Mhm.
okay? And then if they have something in between or less, there's probably a GSM or
Mhm.
hormonally mediated picture in there, or there's an inflammatory discharge like DIV,
Mhm.
right? There's something going on that you can catch if you just look at the clitoris. The other thing is some people have nerve-related pain,
Right.
pudendal neuralgia, or genitofemoral or genitoinguinal, right? And so there's nerve distribution to all of these things. And so people can have clitoral pain and they won't tell you unless you ask them or unless you're examining the clitoris, and then it all comes out, right? And so examining the clitoris is number one. Number two, examine the pelvic floor muscles. Which
Oh my gosh.
you're a gynecologist. But we could help so many people with pain conditions, pelvic pain, vulvar pain conditions, if we would just examine the pelvic floor muscles and readily refer to a pelvic
Mhm.
floor physiotherapist. These are two super easy things to do that would make a world of difference for all of your patients.
Right. And that don't take any additional time. You're already doing the examination. So you're there, the patient is undressed, they're in lithotomy, you're already performing that exam. So that doesn't add any time. And even if you, as the physician, don't want to address those conditions, you can at least point the patient in the right direction so she doesn't feel dismissed or told that her symptoms are not real, or just doing a yeast swab and saying, well, my yeast swab was negative, everything is fine.
Absolutely. One caveat to that, and hopefully things are changing, but it's always important to tell the patient what you're looking at and what you're examining before you examine, right? Because we characteristically, for years and years and years, never examined the clitoris,
Mhm.
it may be a surprise to your patient if all of a sudden we're examining the clitoris, right?
Right.
So it's so important to say, I'm looking at all of the anatomy, both the vulva as well as the vagina. We're going to start out here with the labia. We're going to look at the clitoris. Tell me, how is your sexual function? Are you able to orgasm? It's very natural to kind of ask these like functional questions as we're looking at somebody's anatomy. But I think it's so important to kind of prep your patient because it characteristically wasn't done for so long. I actually learned that the hard way because I was a clerkship director, so I was teaching medical students for about 10 years. And so, of course, all my medical students learned a pelvic floor exam and how to evaluate the clitoris. But we got in trouble one time because one of my medical students was examining somebody's clitoris, and the patient was very upset because she didn't understand that that was actually a part of our examination. So it was a great teaching moment. But I always like to bring that up, the importance of talking through these things, especially when we're doing something that may not be as commonly done, but it should be.
Absolutely. And I mean, I think one of the primary roles of being a physician is education, educating your patient as you go through. So maybe the beginning part of the visit is gathering information, of course, but it's such a great opportunity during a pelvic exam to say, I'm starting up here. This is your clitoris. I'm going to examine that first. It has a small hood over it. Let me check and see. And all of those functional questions naturally flow from that. Sexual health. Are you having vaginal discharge, burning, bleeding if they're postmenopausal? And then talking your way through the entire exam really makes the patient feel so much less anxiety. There's not a woman on the planet who enjoys a pelvic exam, but we can really bring a lot of that anxiety down when she realizes, okay, we're taking this time to complete a really thorough exam.
Absolutely. And same with the vestibule, really educating someone on what the vestibule is, right? I always say, theaters have vestibules. It's like the opening.
One step in the door.
Exactly. And so those natural questions that we may feel uncomfortable asking apropos of nothing,
Mhm.
seem very relevant when we're saying, well, I'm looking at the vestibule, which is your vaginal opening. And I usually joke that it's the foyer of the vagina.
Much
And
fancier.
yes, and so you can ask these questions like, have you noticed any dryness? Do you have any pain with insertion, right? As we're examining the vestibule, right? And
Right.
so this takes no extra time. You're just kind of talking through as you're doing the exam, yet you're able to pick up a lot of these pain conditions that will often go unaddressed
Right.
unless we bring them up. And there have been studies that have shown that people with vulvar pain conditions, they want their doctor to ask about them. They're not likely to bring them up unless they're severely affecting their lives. And then the clinician doesn't feel comfortable asking. So this solves the problem on all fronts.
What resources are available for patients to find out if they have a specialist like you in their area?
There is a directory
Mhm.
for both lichen sclerosis as well as vulvodynia. There's a number of directories.
Mhm.
So for Lichen Sclerosis Support Network has a fabulous provider directory, and you can go in and search by location for that. And then ISWISH has a provider directory as well. ISSVD has a provider directory, and then National Vulvodynia Association. In addition, just because I'm overlapped with some of these conditions, Pudendal Hope,
Mhm.
also Pudendal Neuralgia Organization, also has a wonderful directory not only for pelvic floor physiotherapists, but for pain management doctors.
That's helpful. Those are great resources that patients can use to find someone in their area and for their needs. That's really helpful.
Absolutely.
Great. Well, thank you so much for spending some time with me this afternoon. It's been great meeting you and speaking with you.
Yes, this has been wonderful. I love talking about all of these conditions and bringing awareness.
Yes, I know, me too. And like you said, the collaborative effort, because there are so many specialties that overlap in this area. And I think the more we collaborate, the better, better for us. I always learn something when I talk to colleagues. I hope to share some knowledge. And then, of course, our patients get better care too.
Absolutely. I also should put a plug in. So, ISWISH, the annual meeting, is coming up. It's the end of February into the beginning of March. That's going to be in Atlanta, Georgia. I am the social media chair for ISWISH. I'm on the board, so I have to
Great.
say. I also, along with Dr. Sarah Signa and Dr. Rachel Rubin, we started a virtual hybrid genitopelvic pain course about 3 years ago now. We did one full session with a hands-on workshop 2 years ago, and then we ran it again last year into this year. And we have our hands-on workshop
Mhm.
coming up the day before the ISWISH annual meeting. So any providers, clinicians who are interested or see patients with these pain conditions, that virtual self-directed with live sessions
Right.
course is really, really helpful to use on your own time and to actively apply what you're learning to your patients in real time. And then the hands-on session, we're going to be going over deep and superficial injections, including levator ani superficial perineal botulinum toxin injections. We're going over, we have a bunch of pelvic floor physical therapists that are teaching us how to do pelvic floor exams. We have how to do a comprehensive vulvar exam. So a lot of really great hands-on opportunities for that as well. And you do have to be registered for the virtual course to be eligible to do the hands-on portion. It's kind of like the 101 needs to happen before you do the 201.
Right. So how can providers get registered for that virtual course?
Yes, so you can go to the ISWISH website or on social media, go to ISWISH office, and all the links are in their bio.
Perfect. Thank you. Thanks for providing that. That's been great. Well, thank you so much. I really have enjoyed this. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.